Good morning and welcome, everyone. Thank you for joining us today. We're very thrilled to have you join us as we dive into a talk about sickle cell anemia. Before I start, I would like to introduce the XYZ Med community. This seed was planted by our very own Dr. Blast, Felix Buru, a level 5 medical student. XYZ Med is a vibrant community of Kenyan medical students dedicated to enhancing medical education in Kenya. They aim to bridge gaps in the current system, which often depends on foreign resources that may not address local healthcare needs. This disconnect can lead to education and preparedness gaps, impacting public awareness and healthcare quality. XYZ Med addresses these challenges by creating a locally relevant educational materials, such as illustrations, case stimulations, and interactive tools. This CME medical students, recognizing that classmates often explain concepts more effectively. Today's CME focuses on sickle cell disease in honor of Sickle Cell Awareness Month. Our speaker, Billy Otieno, will share his insights on this critical topic. On to introducing the main person today, one who so courageously volunteered to kickstart these series, Dr. Blast Billy Otieno. Billy is a sixth-year medical student at University of Nairobi with a BSc in physiology. With a knack for research and teaching and blend of academic knowledge and hands-on experience, he is here to share some truly valuable insights. Let's give him a warm welcome and get ready for a fantastic session. If you have any questions, please type it in the chat box, although we will have time for a Q&A session at the end. Thank you. Over to you, Billy.
Oh, thank you, Kavisha, for the introduction. So let me just share my screen. Give me a second. Okay. Can you see my screen?
Yes, we can.
Okay, just a second. Okay. Okay, so my name is Billy Otieno, as I've been introduced by Kavisha. And if you were to talk about sickle cell, this is something you can talk about the whole day, even probably a week. So I'll just be giving you a brief overview of what sickle cell disease is about. Yeah. Okay, so I implore you that every time you're talking about a disease, always try to know the definition. So use the etiology format, so like etiology, and then the pathophysiology, clinical presentation, investigations, and management. Yeah, for every disease that you're covering in your entire medical life, just try to do that. So for sickle cell disease, we'll probably do the same thing about that. Okay, so let's start with the etiology of sickle cell. So sickle cell disease is basically a disease of hemoglobin. So it's known as a hemoglobinopathy in essence. That's what it's actually known as. It's a disease of the hemoglobin molecule. I don't know if you can remember the structure of a red cell, but the red cell had a molecule known as hemoglobin. And hemoglobin, I think I had let me just see if I can. Just a second. I don't know what has happened. It has refused. Okay, it's fine. Anyway, so it's a hemoglobinopathy, it's a disease of hemoglobin. Hemoglobin is normally made up of the heme molecule and protein. The protein is known as globulins. You have alpha globulins and beta globulins. Now, in a sickle cell, it's basic. You find that it's a disease of the beta globulin gene, where now there is a substitution of a certain molecule for a certain molecule that we're going to see in the pathophysiology. But for the brief introduction, so for etiology, sickle cell originated in West Africa, where it has the highest prevalence. It also has a very high prevalence in East Africa. But the place where we find the highest prevalence is normally in West Africa. And it actually originated from Benin. It's one of the countries in West Africa. It also has one of the highest prevalences of sickle cells found in Nigeria. And why has sickle cell disease persisted? It's one of the diseases with the highest mortality, but again, it has persisted over the centuries, and this is because of the sickle cell trait. And it's we find people who have the trait. It's an evolutionary benefit in that they can't have, or even if they have, they manage to get malaria, they'll get the mild forms of falciparum malaria, which is actually the most severe form of malaria. Yeah. And the mode of inheritance is normally autosomal recessive inheritance. So if you look at the gender predilection, is male and female, is the ratio is 1:1. And these red cells, they normally have reduced lifespan. If you can remember, the lifespan of a red cell is around 4 months or 120 days. But in sickle cell disease, around 10 to 20 days, so 16 days. And people don't actually know this, but there's an actual distinction between sickle cell disease and sickle cell anemia. Sickle cell anemia is one of the forms of sickle cell disease. Sickle cell disease is a spectrum. It's a spectrum of diseases where there's a genetic mutation in the beta globin, forming the HBS hemoglobin molecule. So if you happen to have more than 50% HBS in your blood, then we say that you have sickle cell disease. And there are various forms of sickle cell diseases. The most common one is HBSS, where the HBS is normally more than 90%. There's also HBSC, HBSB plus, HBSB0. Yeah, and sickle cell anemia, the most common forms are HBSS, and yeah, this is known as 0 beta HBS. Yeah, those are the two most common forms of sickle cell anemia. And those people who also have the HBAS trait, we don't classify them as sickle cell disease because the HBS is less than 50%, it's roughly 40%. We only classify as sickle cell disease if the HBS is more than 50. For HBS, for the sickle cell trait, they have 40% HBS. They don't normally have the anemia. They have reduced renal concentration. So it's basically a risk factor for renal failure if you have this trait. And therefore, they can also present with hematuria. Yeah, so isostenuria is where you have reduced renal concentrating capacity. So this is how it's transmitted, the sickle cell gene. Now, if one is a carrier mother, carrier father, it's autosomal recessive. So one of the children will be affected. Or like this, or 1 in 4 chance that one of the children is going to be affected. Yeah, so if you look at the epidemiology, it's the sickle cell belt, the one in green. As you can see, it's mainly a tropic disease where it's found in Africa, in the Mediterranean region. And thalassemia is a disease of also the Mediterranean region and Asia, India, then HBC, and those places. Then in Africa, you can see Nigeria has a very high carrier frequency. Kenya is also there. In the Eastern Mediterranean, India is also a very high carrier rate or carrier frequency. And then in Kenya, if you look at the ethnic communities, you find it high in Komos, Taveta, the Luo community. And if you look at where these people are settled in Kenya, you realize it's mainly in areas where there's high malaria prevalence. And that's why we were saying that there's that relationship between sickle cell and malaria. So you may be asking yourself, why is it that people with sickle cell trait experience less severe forms of malaria? It's because the sickle cells, they normally provide a very hostile environment for the malarial parasites. And also the malarial parasites can't easily get inside the red cells. Yeah, so that's one of the main reasons. But I want you to remember this, is that sickle cell trait, mild forms of malaria, but sickle cell anemia itself the forms of malaria are normally very, very severe. It has a very high mortality compared to the general population. Right. So we have talked about the etiology, I've talked about the epidemiology. And the next thing, let's talk about the pathophysiology. I like describing this using a diagram. I don't know if I can't see. Okay. So what happens now in sickle cell anemia? If you look at the genes or the genome of someone with sickle cell anemia, you'll see that the substitution of adenine with thymine, that substitution in the gene normally causes substitution of amino acid now, this production of valine instead of glutamate. And that one simple amino acid is able to cause all the manifestations that we see in a sickle cell patient. Just one simple substitution of one of the DNA bases causes that one. So you can see how complex we are. Anyway, so once we have the substitution, we have now the HbS. The normal form, the adult hemoglobin is normally HbA. But in a sickle cell patient, we have HbS instead. If you can look at this diagram, when there is oxygenation, the red cells are far apart. But when there's deoxygenation now, the HbS normally forms polymers. What I mean by polymers is that there is going to be decreased solubility and therefore increased thickness. It's like they form a gel. This gel has also been described as tactoids. And this gel is the one that will result in the sickling. Yeah, so that's how it normally happens. So in deoxygenation, we have formation of HbS polymers. The polymers have reduced solubility and increased viscosity or thickness, and this result in the sickling process. Yeah, I think I also had a diagram for that. So this is like basically what happens in the cell, the physiological mechanisms, or rather the pathological mechanisms. So what happens when there is this formation of polymers, this increase intracellular calcium that causes the activation of a channel known as Gauss channels. Gauss channels are basically just potassium efflux channels. And what happens now, you remember for those who have done pathology is that whenever a cell is about to die, there's normally increased cytosolic calcium. So when the cell, the cell membrane has been disturbed, there is going to be increased cytosolic calcium, which causes activation of the Gauss channels, which causes potassium efflux. And that will result in the sickling process. And this is the same reason the potassium efflux is the same reason that a malaria parasite cannot survive inside a sickle cell. Yeah, but anyway, once you have the sickling, the cell can normally go back or revert to its normal biconcave shape. But now continuous deoxygenation normally results in irreversible sickling. And when you have irreversible sickling, there's decreased production of nitric oxide. Nitric oxide is normally a potent vasodilator. So without it, there's also going to be vasoconstriction. So when you have vasoconstriction at the same time you have irreversibly sickled cells, there's going to be vasoocclusion. And vasoocclusion is the main clinical manifestation in sickle cell anemia. It's the main symptom that patients present with in a hospital. It's normally because of vasoocclusion. And we're going to talk about a certain crisis known as the vaso-occlusive crisis, and I'm going to describe it more. So that is how everything happens from the top. This is a very famous diagram. So from thymine substitute for adenine, you get your substitution from glutamate to valine, and then when there's deoxygenation, you have sickling, formation of polymers, and then sickling of the red cells, and then this occlusion of blood vessels and decreased production of nitric oxide. So that's the simple pathophysiology of sickle cell anemia. So what normally triggers this sickling? We have, they're basically just called triggers. You can have infections, hypoxia, acidosis, exercise, extremes of temperature, emotional stress. So there are very many things. Infections itself can trigger sickling, hypoxia, acidosis. Yeah, and I've talked about how low oxygen tension causes the decreased solubility, increased viscosity and polymer formation, and the irreversible sickling, and how the sickle cells also adhere to endothelium. I don't know if I should talk about this, but just remember the sickle cells, they normally present, they have a very high presentation of vascular, one of the CAMs, VCAM, and that causes the adherence to the endothelium, increased thickness, which eventually leads to vasocclusion. Yeah. So clinical presentation, I like doing this head to toe. But before we go to the head to toe format, I just want us to know something briefly about how sickle cell presents. So sickle cell, it doesn't present in the first 3 to 6 months of life because infants normally have HbF, which are there for some time and therefore they're protected. So the clinical manifestations usually start to appear after 6 months. But another thing I want you to remember is that the first symptom of anemia that normally presents is normally anemia itself. Yeah, but before that, the children are okay. In the US, there's mandatory neonatal screening for sickle cell. In Kenya, we don't have that. Yeah, so after 3 months, the patients will start presenting with frequent infections. You'll come to know why, the pain, anemia, splenomegaly, and later jaundice. Jaundice is normally due to increased breakdown of red cells. Hemolysis, whenever you have hemolytic anemia, the hallmark is jaundice. So sickle cell is a form of hemolytic anemia. If I can remember correctly, hemolytic anemia, it's one of the non-immune. It's non-immune and it's hemoglobinopathy. Yeah. And then from 6 to 9 months, the first symptom, another symptom that will present is hand-foot syndrome. Hand-foot syndrome is basically dactylitis, where you have inflammation of both the dorsum of the hand. It's bilateral inflammation of the dorsum of the hand and foot. It's known as hand-foot syndrome, and it's a common pediatric manifestation. And then for the spleen, initially you have splenomegaly, but with the time we have recurrent vasocclusion in the spleen, it results in splenectomy, which causes hyposplenism. And when you don't have your spleen, remember the spleen is one of the immune organs. Without the spleen, and again, the spleen it produces the immune cells there produces antibodies. Remember, one of the functions of antibodies was opsonization. So without the antibodies, you can't have opsonization for capsulated microorganisms like Streptococcus pneumonia, Salmonella, Meningococcus, even for viruses like influenza. And then you find that Salmonella osteomyelitis, it's a common it's a common cause of osteomyelitis in patients with sickle cell anemia. Though there's always this question, if I remember, which is the most common cause of osteomyelitis in sickle cell patients? The answer is still Staphylococcus aureus. It's only that if you find a patient with Salmonella osteomyelitis, there's a very high chance the patient has sickle cell. Yeah, but still the highest prevalence of osteomyelitis is normally still due to Staphylococcus aureus. Yeah, so this is dactylitis. You can see inflammation at the dorsum of the hand. And then there is frontal bossing. Bossing is normally due to, in hemolytic anemia, the bone marrow is trying to compensate for the increased breakdown of red cells. So there is bossing or this increased utilization of marrow in the head. And another thing, in hemolytic anemia, also have the hepatosplenomegaly. Hepatosplenomegaly, we normally have them because remember in utero, production of red cells is normally red cells are produced by the liver and the spleen, but they never lose their red cell generation capacity. They're only replaced by the bone marrow. So when you have hemolytic anemia, or like in sickle cell anemia where we have chronic hemolysis, the bone marrow will of course expand for the increased red cell breakdown, and the liver and the spleen will also become bigger to also do the same thing. So they never lose their erythropoietic activity. They just become dormant and the bone marrow replaces them. This is again cortical thinning and shortening of the digits that happens in sickle cell because of when you have vasocclusion of vessels that take blood to the bones. And in children, we normally have cortical thinning of the small bones, but in adults, you have cortical thinning of the weight-bearing bones like head of the femur, and it's normally bilateral, especially for adults. So in adults, it's long bones, in children, it's small bones. So this is most probably a child. The fingers are very long. And then this is now, no, in sickle we have acute presentation and chronic presentation. So chronic presentation, we have these leg ulcers. It's a chronic presentation and it's normally due to vasocclusion of veins. So the blood pulls behind and there is tissue damage and tissue infection. Yeah, so before I go to the crisis, I like to in the head clinical manifestation of sickle cell. So sickle cell affects almost every organ in the body. Every organ you think about, just remember there's a way sickle cell affects it. So if you can start from the head, you have our brain there. When you have a occlusion of the blood vessels in the brain, you probably have a stroke or a CVA. In your eyes, you'll have proliferative retinopathy, those corkscrew appearance. And then just go down to your chest. In your chest, you have pulmonary hypertension. Remember, I talked about nitric oxide decreased production. So when you have decreased production of nitric oxide in your lungs, you'll probably have pulmonary hypertension. It's one of the, it's like 25% sickle cell patients have this pulmonary hypertension. We also have acute chest syndrome in the chest, causes cardiomyopathy. So when you have the dilation of two ventricles and the left atrium, and the left atrium in sickle cell, you can also have the cardiomyopathy there. So I've talked about the lungs, about the heart there, in the chest. In the abdomen, we have your spleen where splenomegaly and splenectomy. In the liver can also cause hepatomegaly, can cause cholelithiasis, cholecystitis. And then in the kidneys, when you have occlusion of the kidneys, you can have AKI and renal failure. So chronic renal failure is one of chronic kidney disease. It's also a common manifestation of sickle cell patients. The age of 25 there, most of them normally have renal failure. And then which other organ have I forgotten in the abdomen? You can have bowel infarction. In the legs, you can have a vascular necrosis of the head of the femur. You can have shortening of digits in the hand, chronic leg ulcers again in the legs. Yeah, so if you do head to toe, you can come up with so many symptoms of sickle cell. In the genitals, you can have priapism. So what normally, sickle cell disease itself, it's a chronic hemolytic state. But then we have crisis. A crisis is an increase in intensity of what is occurring in steady state. In steady state, there is a vasocclusion, there is hemolysis. But now a crisis is when there's increased vasocclusion, basically. So we normally have four main types of crisis, and it's the crisis that bring patients to hospital. The most common one, again, I repeat, is painful vaso-occlusive crisis, so known as just vaso-occlusive crisis. But you also have other crises like hemolytic crisis, aplastic crisis, and visceral sequestration crisis. So hemolytic crisis is basically when you have increased hemolysis. It's a chronic hemolytic state, but when now the intensity of the hemolysis increases, we call it the hemolytic crisis. And then another one is the painful vaso-occlusive crisis. So it ranges from dactylitis, can have severe back pain because of infarction of the vertebral column, chest pain, have abdominal pain. So it's acute abdomen, symptoms of acute abdomen you can have. Yeah. Again, you can have acute chest syndrome. Acute chest syndrome is normally caused, I think it has three causes, if I can remember correctly. First one was because of fat embolism. So when you have infarction of bones, the fat normally embolite the chest, where it causes it manifests similar to pulmonary DVT. Another thing can be due to infection. Pneumococcal infection can cause the acute chest syndrome. And another form of painful vaso-occlusive crisis is stroke and priapism. So this is all these 7 painful vaso-occlusive crises because of occlusion. Yeah. And then aplastic crisis, it has 2 main causes. In aplastic crisis is when the bone marrow fails to produce red cells. So it can be due to B19 infection, parvovirus, which will specifically inhibit the red cell progenitor cells. Therefore, there's a decreased production of red cells. Other cause can be due to folate deficiency. Remember sickle cell, whenever you have chronic hemolysis, you're losing folate because folate is used in production of cells, DNA and everything. So whenever you have chronic hemolysis, just like in sickle cell, you're going to have folate deficiency. And if you cannot replenish the folate stores, then you can have the aplastic crisis. One thing about the aplastic crisis is a self-limiting state, and especially for the B19 parvovirus. Yeah, so it just goes away after 3 days. And then the last one is a visceral sequestration crisis. The most common form of visceral sequestration happens in the spleen, but it can also happen in the liver. It can happen in the chest. I've seen some books saying acute chest syndrome is a form of visceral sequestration. The most books normally put it as a painful vaso-occlusive crisis. In visceral sequestration, you have when you have sickling in the spleen, for example, there is pooling of blood, say traps a lot of blood inside there. So there is a predominant increased red cell count. So in a plastic crisis, there's reduced reticulocyte count, but in visceral, there is increased. Similar to hemolytic crisis, is increased reticulocyte count. So maybe you can just go more about on the crisis, the 4 crises. This one is a must know, and just read about how they present, how you investigate for them, and how you manage. So, for example, like acute chest syndrome, the patients may in children they present with fever, so you can mistake it for pneumonia. In adults, they don't have fever, and they are febrile. So they present in a similar way too. Pneumonia, so shortness of breath, chest pain, there's even sputum production and everything. And now the investigations that you do are chest X-rays, where you'll see even a pulmonary infiltration similar to a pneumonia. And you can also do investigations like blood cultures and sputum analysis. And you also give oxygen. So you kind of manage them, investigate and manage for them the same way. Priapism is normally because of vaso-occlusion in the penis. There can be the normally high flow, and I remember also low flow. High flow when you occlude the arteries, low flow is when you occlude the veins, and the vein one is the most the one that has the worst manifestation. Normally the one that occludes the veins. And it can eventually lead to impotence if it's not treated immediately. So most of these crises are things that are supposed to be handled immediately because there's a very high risk of death. Okay, so after we have now talked about the etiology, we've talked about physiology, we've talked about clinical presentation. But the next thing we talk about is the investigation. And it's like we're handling the patient for the first time. So if the patient has those symptoms, there's a very high chance we'll be suspecting the patient has sickle cell anemia. So we'll do the investigations for diagnosis. So the first thing that, of course, we normally do is a full hemogram or a complete blood count. So you're going to find that the patient has low hemoglobin. So all the red cell indices are going to drop. So from hemoglobin is going to be low, hematocrit is going to be low, and also reduced cell count. And then, so those are reduced red cell values. For the indices, they're also going to decrease. So like MCH, decrease MCH to less than 76. No, sorry, that's MCV. Decrease MCV to less than 76. and also decrease those the conflicting texts. Some say that sickle cell is a predominant microcytic anemia. Some say it's predominant macrocytic anemia. So you can go find out if it is a macrocytic form or is it a microcytic form. But from me, what I found for a long time is that it's macrocytic because you have loss of folate. Anyway, so other than anemia, remember we have the cytosis. You have thrombocytosis, leukocytosis, and reticulocytosis. Except you only don't have reticulocytosis in a plastic crisis because you have affected the red cell progenitors. So remember, reticulocytes come from red cell progenitors. So if you have a plastic crisis, you have affected the red cell progenitors, and therefore you can't have increased reticulocytes. But in the other ones, in chronic hemolysis, you must have reticulocytes in blood, compensate for the loss of red cells. So after the full hemogram and the reticulocyte count, the next thing we do is a PBF. In the PBF, we're going to see our sickle cells and target cells, and also probably macrocytes. And macrocytes, we know them by looking at the lymphocytes. So we compare them to the size of the lymphocyte. After the PBF, the next test, we do screening tests. So you can do 2 screening tests. You can either do a sickling test or a solubility test. In sickle cell, we are going to, and for the solubility test, the cells are going to have reduced solubility. You can just Google the picture on solubility test and you see how they present. So in sickle cells, they normally have reduced solubility and therefore they have increased thickness. You can't see through the test. For the sickling test, we apply a sickling agent, I think like sodium metabisulfite or sodium dichromate something. And then that will induce the sickling of the red cells. The only problem with the screening tests, just like any other screening test, is that they normally have no specificity and no sensitivity. So like for sickling test, it has a very low specificity and it cannot differentiate the trait from the disease. And it's also not recommended in infants because they still have the HbF that I talked about earlier. Another test you can do is the LDH. Whenever you have hemolysis, the lactate dehydrogenase levels always increase. Whenever you break down any cells, the lactate levels will increase. And then the confirmatory tests, we have hemoglobin electrophoresis. There are normally 3 confirmatory tests. The most common pediatric one is isoelectric focusing, especially in developed countries. But in a country like ours, we have hemoglobin electrophoresis, and though it doesn't happen, but we also have HPLC, high performance liquid chromatography. So those are the 3 confirmatory tests for sickle cell anemia: hemoglobin electrophoresis, isoelectric focusing, and high performance liquid chromatography. In electrophoresis, just like any other electrophoresis, we separate cells based on their charge. Yeah, so that's when you can read more about it. So that's how you diagnose sickle cell. You start evaluating for how the patient presents, then you go down like that. And then when you're investigating, you can also investigate for management. So if they have liver problems, or even if they present with jaundice, you must do LFTs. If they present with symptoms of AKI, you can do renal function tests. They present with syndrome, you can do chest X-ray. If they're febrile, you can do blood cultures, even urine cultures. Yeah, UTIs, there's a very high prevalence of UTI among sickle cell patients. You can also do abdominal ultrasound if they present symptoms of acute abdomen. And you can also investigate for pancreatitis, cholelithiasis, just as stones. You can do transcranial Doppler in CNS disease if you're evaluating for stroke. Also do X-rays for the hips and hands. Okay, so definitive management is always a 9-step process. Some people say 7, some people say 10. Yeah. Apart from, I've not done supportive management, and I've not done the individual crisis, how you manage, and you can just go read more about that. But for definitive management, just follow these 9 steps. So like the first one is penicillin prophylaxis. You give penicillin V for a certain period of time. So, like for children, you give them daily, I think up to 5 years. Then remember, we give penicillin because they are prone to infections, especially for encapsulated bacteria. You should always give penicillin prophylaxis, and we give Pen V. Pen V is the oral one. Number 2, you can give you do the regular immunization. So pneumococcal immunization, you can give them a booster. Meningococcal is not in the KP schedule, but it's given. You can give Haemophilus influenza type B, and you can also give the influenza vaccine, I think annually. Okay, remember you're protecting against the capsulated bacteria. The third one is hydroxyurea. Hydroxyurea is an antimetabolite. It functions by increasing the levels of HbF, fetal hemoglobin. Remember I said that infants are normally protected against sickle cell because they have HbF. But HbF normally reduces with the time, so that is replaced by another form of hemoglobin. But now, if you give them hydroxyurea, there's going to be an increased production of HbF, and therefore it persists. I think the only problem with HbF is that it holds more to the oxygen compared to the adult hemoglobin. It doesn't release it as easily. But it's better than having the HbS. And then another management protocol is blood transfusion. You can do simple or exchange, or in some cases you can do chronic transfusion therapy, where you just ensure that you maintain your hemoglobin levels at a certain range. You just do the chronic. I think after like a month, the patient comes, it's given, you do the same way, even if the patient doesn't have anemia. It's just given to ensure that the hemoglobin levels are up there. And then the fifth management protocol is analgesics for pain. You can do paracetamol, you can do NSAIDs, you can do morphine. There's the ladder thing based on how the patient presents. Another thing is the psychosocial support. Most people know this, but most of these patients are children. And for a child, start asking themselves, why me? Things like that. So they need the psychosocial support, which for me is even the most important thing. Because emotional stress can itself be a trigger for sickle cell. So you need to ensure that the patient is in the right state of mind for medication and the prognosis and everything. So psychosocial support is important. Also for the parent, both the child and the parent, they require the psychosocial support. Another thing is the nutritional support and folate. So the diet should be okay. They should ensure continuous hydration and folate, because remember, this is a chronic hemolytic state. Therefore, they need the folate. And remember, the folate will also avert the aplastic crisis. So yeah, folate because of the chronic hemolysis. Another thing is malaria prophylaxis. Remember, I said that sickle cell disease has a very high mortality when they are infected with malaria. Therefore, they require this malaria prophylaxis to reduce to prevent them from getting malaria. So you can do the medication prophylaxis where you give them drugs like doxycycline and tobacco, or you can use the non-pharmacological way of giving insecticide-treated nets, clearing of bushes, drainage of swamps, just to prevent them from getting malaria. And then routine review visits. You should always review your patient. So this is how we definitively manage a sickle cell patient. Follow these 9 principles, your patient will be okay. Most probably okay. And then I also wanted to talk about 2 important new discoveries, how things are happening in. And whenever you're talking about definitive management, always try to talk about the counseling part. And when you're discharging your patient, I think that the patient is also part of the definitive management, because you are handling a human being here. So in research, I want to talk about the CRISPR-Cas9 system. It's CRISPR-Cas9. For those who have come across this, CRISPR-Cas9 is was the paper was this. It's a scientific technology, and for me, it's actually the holy grail in medicine. And in the 21st century, it's a very important discovery. And how I see it is, even the people who discovered this, they won a Nobel Prize some years back, 2012, in chemistry. Yeah, so it's a very important scientific discovery. The CRISPR-Cas9 system, you can go read about it. CRISPR itself is a DNA sequence from in bacteria, from bacteriophages. Cas9 is an enzyme. But in what I mean in simple terms, the CRISPR is just a DNA editing tool. So where we can target a specific DNA sequence, and we can insert, we can remove, can duplicate, we can do anything we want. Yeah, so for like a patient with sickle cell, what is happening in current research is that they take the hematopoietic stem cells and they culture them. Once you culture them, they target now the gene for HbF. Remember, it normally becomes dormant with time, but now they induce it. Once they induce it, they transfer it back to the patient. One thing that I forgot to mention is that stem cell transplant is normally curative for a patient with sickle cell. But the only problem with stem cell transplant is that these patients will forever be on immunosuppressive therapy, not to mention because of the GVHD, graft versus host disease. So you give them the immunosuppressive therapy. Remember, it also these drugs, they have a lot of side effects. That's why they came up with this CRISPR system was a better alternative. And CRISPR can do so many things in medicine. It's, for me, that's why I was saying it's the holy grail in medicine, where you can fix almost all genetic mutations in human beings. The only problem is, ethics. People are saying that you're interfering with human DNA, and people are worried about the future, the offspring, and everything. Yeah. So, but anyway, for this one, once you induce your HbF, this person you transfuse back the cell, and of course the patient won't be on any more, the patient would be on immunosuppressive therapy because these are cells from their own body. Yeah, so it's an autologous mechanism. We don't get the cells from any other person, so there's no role of immunosuppressive therapy. Yeah, so the only side effects again for this CRISPR system is that you may interfere with other genes that are not part of the genes that you never intended to interfere with, and it's a very common side effect, and probably the scientists are working on that right now. So anyway, the first research was in CRISPR system. You can go read about the CRISPR system, and it's so many things in science. Another thing is the Gados channels that I talked about earlier. Sickling is normally because of increase in intracellular calcium, which activates the Gados channels, causing the potassium efflux. So what happens if you have Gados channel inhibitors? There won't be any sickling. This is a research that has been happening for almost 30 years now, and there was this drug, I think Cytopec or something like that. It has been, I don't know if it was endorsed by FDA or any other regulatory body, but yeah, probably the research is still continuing. Remember, if you inhibit the Gados channel, you won't be able to have any form of sickling. That's the theory, but again, if you took a ground, if you go out there and try to do it, that doesn't normally happen. Yeah, so Gados channel inhibitors and also the CRISPR system. So there is such papers that I came across for this, and if these things are able to help the patient with sickle cell anemia, then it will be good, because it's a disease that first time it was published was in the year 19, more than a century, and we haven't made any significant progress. So it can be a very big research topic, especially because it's a Black person's disease or an African disease. Mainly affects probably 99% look at the human population and 10% Black people. So yeah, because we're in Africa, so in Africa, and Africa is our business. So we should work on eradicating such diseases. Yeah, I think that is the end of my presentation. So I tried to be as brief as possible and give you the basics on sickle cell. But if we talk about this, we'll probably talk about it the whole day. Yeah. So any questions?
That was an incredible presentation, Billy. You provided us with lots of valuable insight and you kept us engaged throughout. Thank you so much. I had mentioned that we will have a Q&A session at the end of this Zoom, like towards the end. So maybe for now, we can all jog our memory, exercise our brain cells with a Kahoot session. Is that okay, Billy?
Yes, I've seen some questions in the chat. Can I do that right now? We can do it after the questions.
Okay, yeah, sure.
Okay, let me see from the top. Please share your slides. Okay, I'll share them. Sodium dithionite. Yeah, I think that was one of the sickling agents other than sodium metabisulfite that I talked about. Immunization is for the capsulated bacteria. Can you remind me the bacterias? I think it's been said there by Doreen. Thank you, Doreen. Okay. But is the okay, the person just wanted to know remind the bacterias. Okay, let's reserve the question. Okay, the oral question that is also influenza meningococcus.
Okay, everyone, we will now have a short Kahoot session. I urge you all to participate, and in order to do so, you can log on to kahoot.com and enter the PIN or scan the QR code that you will see in a minute. So, excuse me, this is the game PIN and that's the QR code. So I believe everyone knows the rules. You just have to be super fast and pick the right answer. And we're going to start in 3, 2, 1. The competition is crazy. You guys have not come here to play. Whoa. The last two questions. Okay, and the last question in 3, 2, 1. Congratulations to our winners. All of you did really well, though. I would now like to invite our winners to say hi, if they're able to. Don't be shy. Husseina. Okay, maybe not.
Hi, the game was really fun. That was like
Yeah,
an interesting.
you did good.
It was a fun way to end the session. You understand where you missed out on some points.
I agree. No, all 3 of you were excellent. Well, all 14 of you were excellent. The 3 of you were excellenter. Okay. I will now open the Q&A session. If there are any questions for the speakers, I now invite you to unmute or ask in the chat box.
Hello.
Hi, Doreen.
Hi, how are you?
Good, thank you. How are you?
Yeah, I'm also good. Yeah, thanks, Willie, for the presentation. It was really profound. Yeah, my question, maybe I might have missed it because I joined late, but I just want clarification. Between sickle trait and sickle cell disease, who are at risk of getting malaria, there have been controversy. Okay, initially, me, I thought it is the sicklers, the one with the disease, but actually it's the other way around. So would you mind clarifying, please? Thank you.
Okay, Doreen, thank you for that question. Sickle cell trait, people who have sickle cell trait, they get malaria, but they have milder forms of malaria. Because apparently the parasite, remember sickle cell trait, they have 40% or less than 40% HBS. The falciparum parasite, it proliferates mainly in HBS subtype. So they will have milder forms of malaria because they have HBS, which doesn't allow malaria to be there in their body. So in HBAS or sickle cell trait, they have milder forms of malaria. And that's why I was saying it's an evolutionary advantage for those people who have HBAS. However, in people who have sickle cell disease, anemia itself, HBSS, they normally have very severe forms of malaria. And it has not been documented why, but that is how just the way it is. They have higher mortality or have more severe malaria compared to the general population for those patients who have sickle cell anemia. But in sickle cell trait, they have milder forms of malaria. So that's the evolutionary advantage. Like the whole essence of sickle cell from an evolution perspective was to confer an evolutionary advantage against malaria. But now came across this, every good thing you must have something bad against it. So now people have the trait had the advantage of continuing their lives irrespective of having malaria in their region. But now the only bad thing that came with it is that now the children or people who have the trait will have the sickle cell anemia, which now has even worse prognosis compared to the general population. I hope I've answered your question.
Okay, thank you.
You have a
Is
question.
there... Yes, David.
Mine has to do with the life expectancy of these patients. How has that changed over time?
The life expectancy is variable, but of course, in our current century, the life expectancy has increased. Before they couldn't even hit 20 years, and most used to die in the before 5 years. But now majority can survive past the 5 years and go even past 25 years. Though their lives won't be good because they'll be in constant pain. In sickle cell, have chronic pain. So they're always in chronic pain, and therefore they should always be on medication. Not to mention even their lives are not as good. And therefore, life expectancy is something that is multifactorial. It's not only about having the disease. Remember also your mental health and everything. Imagine you can't even have children because you have very high chances of getting spontaneous abortions, things like that. So the life expectancy has increased, but the livelihood hasn't been as much better. So we need more research to improve their life expectancy to the one that the general population enjoys. So yeah, that's my answer to your question.
Thank you, and thank you for the presentation as well.
Okay, welcome. Okay, if there isn't any other question, I think I can close it there.
Okay, if there are no more questions, I would like you all to get ready to meet the visionary who turned a simple idea into this community. Felix is a fifth-year medical student who is definitely a jack of all trades. I now yield the floor to Felix.
Thanks. Hi, Kavisha. Hi, everyone else. Thank you for that introduction.
Hello.
So thanks, Billy. That was a really nice presentation. I really enjoyed it. I've learned so much. And thank you for all who've just joined and learned and engaged. The whole idea behind this series, it's going to be a weekly series. So I hope this is not the last time we're seeing you. So every Saturday, same time, for just an hour, various topics. And it's just meant to promote peer-to-peer learning. Most of the things personally that I've learned throughout medical school have come from my peers. Like, Billy, when we were in second year, and first year, he'd teach us so many things, and just different people. You pick up so much information from your peers. And often it's your classmates who can explain concepts in a way that you can understand, sometimes even much better than professors. And that is just the whole idea behind this. We have various platforms on social media that you can engage with us and just consume the various forms of content that will be coming, and much more is going to be coming. So thanks once again for joining, and have a lovely weekend, and we hope to see you again next weekend. Thank you, and yes, have a nice weekend. Kwaherini. And the recording will be shared on YouTube. Thanks.
Okay, thank you, Felix, and thank you everyone for joining our very first CME. Thank you, Billy, for that great presentation.
You're welcome.